Thank you, Dr. Marshall, for the invitation to join the CARE faculty today. I have the opportunity and privilege to present to you some of the most compelling liver data from the recent ACG and UEW meetings. This is obviously a difficult task as the amount of liver content is far dwarfed by the gastrointestinal content at these meetings. However, as I've come to learn now after doing this program for a couple of years, there are a lot of very important liver nuggets to be found amongst the data. So as I go through the data myself, I really feel like this is me standing at the top of a haystack looking for that needle, of course, being the important liver paper. And what I hope to present to you today is some of the needles. So I'm going to broadly talk about three different topics. I'm going to talk a bit about fatty liver and some of the data relating to fatty liver that would be found at these meetings. I'm going to talk about cirrhosis and its complications. And finally, I'll talk about viral hepatitis. So I welcome you to join me on this journey for the next 15 or 20 minutes. So fatty liver is the epidemic that used to be unseen in North America, but is now truly bubbling up from the bottoms. It is going to be the #1 indication for liver transplant in the near future. So I think all of us as gastroenterologists, infectious disease docs, and primary care physicians, or whatever your role may be, are going to have to know a little bit more about this condition and perhaps how to recognize it and what to do about it, especially when it causes severe liver disease. So this is a great cartoon I found. I think it's from New York City's banning of trans fats, and the reading is, now banning trans fats has had quite an impact. And of course you see skinny Santa there. So it goes without saying that our entire society needs to make some behavioral changes to prevent this condition. So the first topic I want to address, and there was an abstract that helped us understand it, was what are the factors that are associated with fatty liver? We know of many, obesity and metabolic syndrome being the most important, but what are some of the other factors that are positively or negatively associated with fatty liver, and that may help us understand the pathophysiology of this disease? So this is oral number 28 from ACG. The title is The Association Between Aspirin Use and the Prevalence of NAFLD. This is actually a data crunch from NHANES, which, as many of you know, is the population health survey that's very comprehensive in the United States. It basically surveys all individuals living in a household and every 2 or 3 years and takes blood samples as well as does a comprehensive paper evaluation on them. So it gives a wealth of data. So this is a cross-sectional study from NHANES 2, which would put us sort of in the middle 2000s. They looked at 11,416 individuals who actually underwent an ultrasound of their abdomen as part of this study. And they identified about 2,889 patients with NAFLD. And if you're doing the math, that works out to a prevalence in a cross-sectional study of the US population of around 25%. And that was 7 or 8 years ago. We're probably looking at 30% prevalence now. And there were about 8,500 controls. And they quantified aspirin use as part of this study as well as either never, occasional, which is every other day at most, and regular, which is almost every day. And what they found was that actually as aspirin use increased in the population, it was inversely associated with fatty liver. So the more aspirin, the less fatty liver individuals had. And this was largely driven by males, and I haven't shown that breakdown, but if you looked at the abstract, you would see it. So this raises the question around, is there something, we talk about fatty liver as a non-inflammatory condition, and we talk about NASH, non-alcoholic steatohepatitis, as the inflammatory disease that can come from NAFLD. But the question here to me is aspirin suppressing some kind of inflammation that is actually contributing to the pathophysiology of fatty liver, Or is this just a correlation issue rather than causation? I think we need more studies to determine this, but it's an interesting area of research, and perhaps one day we may be using aspirin to prevent fatty liver. I'm going to go on to predicting cirrhosis in fatty liver. This is a critical issue for all of us who see these patients, because if we followed them all forever, we would be overwhelmed in our practices. So how do we pick out the patients who are at risk of cirrhosis or have already developed cirrhosis and are at risk of liver complications from this condition? So this is UEGW's poster 44, and it looked at something called the PLALA score, which I'll tell you about, to predict cirrhosis in non-alcoholic fatty liver disease. Now, this was a Japanese study, 1,048 Japanese patients with biopsy-proven non-alcoholic steatohepatitis. Only 38 of these patients were cirrhotic, which is a fairly low proportion for a biopsied population. However, it was a large NASH population that had been biopsied, and I think the results are important because of that. So if you look at the PLALA score, it's made of three components: the platelet count, the albumin, and the AST to ALT ratio. And based on each of those values, you're given a score of 0 or 1. So for example, if your platelet count is less than 153, you're given a score of 1. And if your albumin count is less than 40, that also counts as a score of 1. You add up the score, and if you have a PLALA score greater than or equal to 2, it predicts cirrhosis with 87% sensitivity and 91% specificity. So this is actually a fairly useful predictor from the statistical point of view, and I think clinically as well, because all of these lab values are readily available on almost every patient with fatty liver that you will see in your practice. So I think that that is a very good thing about this score. It will need to be applied in more than just a Japanese population to know that it is valid for us in our practice, but I think that it's something that you could, calculate or even just get a kind of a gestalt for when you see the patient and use in your practice. So I'm going to transition now to cirrhosis and complications, and I love this cartoon. I feel like this might be me. You may not need a liver transplant after all, and of course the patient says, I'll drink to that. But definitely goes to show you that not everyone is fully aware of what caused their liver disease in the first place. So I'm going to talk about Refaxamin here. This is a novel antibiotic, non-absorbed, that's been approved by the FDA for both irritable bowel syndrome and for hepatic encephalopathy. And I'm going to talk about Refaxamin and its role in the treatment of hepatic encephalopathy. So this is poster 1479 from ACG. This is a study of daily single-dose Refaxamin for the prevention of hepatic encephalopathy. Now, the background to this study is that in the New England Journal of Medicine in 2010, there was a phase 3 randomized control trial of twice-daily Refaxamin plus lactulose versus placebo in patients who had developed hepatic encephalopathy as a tool to prevent them from developing hepatic encephalopathy again. And there was actually a very significant difference between the group that received Refaxamin and the group did not. In Canada last year, this drug was finally approved by Health Canada, but at a very significant cost. At a twice-daily dose of Refaxamin, it's about $1,200 a month. And if you think about most of your patients with very difficult to control encephalopathy, they are not exactly the population that's going to be able to afford that for various reasons, the most obvious being that they don't work. And this is a drug that's currently not reimbursed by any provincial drug plan. So this study was done in Pakistan, and it's actually a study of once daily versus twice daily dosing. It was a randomized control trial with 300 patients, and they used the same formulation of Refaxamin that we have in Canada, 550 milligram tablets, once a day or twice a day, in a relatively sick population that was mostly Child's B, and followed them for 6 months. And here you have the results. Essentially, there is no difference between the once daily group and the twice daily group in terms of breakthrough hepatic encephalopathy at 6 months. So based on this study, single daily dosing appears to be sufficient for Refaxamin. And this may mean that we can prescribe rifaximin at half the recommended dose, have the data to do it, and possibly improve access for people that are going to be paying out of pocket. So with that, I'd like to pause to take some questions. And I think there may be some interesting comments about the data that I've presented so far.